As you can see, we have quite a busy program, but it's actually really nice and it's fun. And you will actually hear some of the things being repeated during the day. So for example, the ISUOG twin guidelines, obviously it's like an overview, but actually there will be, when you have the speakers talking about the individual topics, there might be a little bit of repetition, but that's okay. We're here to learn, and repetition actually is good for learning. So the ISUOG guidelines was published in 2016 in print, but actually it was available on the website, like online, from about 2015, and a very large number of experts in the field have contributed to it. And if you see the guideline, ISUOG guidelines, and the number of the downloads, you see that actually the ISUOG, the twin guidelines, the number of downloads is more than 34,000. If you compare that with the rest of the ISUOG guideline, we are second after the first trimester ultrasound, which was published about 3 years before that. So the message is that it is actually a popular guideline. Yeah. So that's your reading. That's your bedtime reading tonight. Okay. When we wrote the guidelines, we tried to actually to assess the quality of the evidence. And as you probably aware, a lot of the guidelines, the statements or the recommendations is not necessarily backed up by fantastic quality or randomized control trials, because it's just the evidence is not there. And therefore, that's why they have, you really want to have experts contributing to it, because they have the expertise. And therefore, sometimes they will actually say, okay, in my experience, I think that would be the right thing to do. Yeah, so, and therefore, when you have the recommendations, it's useful to know what grade of the recommendation. So at least you know, do I have to really stick with that, or can I disagree, for example? You shouldn't disagree, but you can. When we actually wrote the guidelines, you have to decide what the scope, because you can't really write everything. So for example, ISUOG is an ultrasound society, and therefore the guideline focuses really on the role of ultrasound. So the role of ultrasound in uncomplicated, the routine care of twin pregnancies, and also the complicated twin pregnancies. Of course, it doesn't really cover things like mode of delivery, for example, because that's not really the emphasis or the scope of the ISUOG. So you can see this is all the stuff that we covered. But let's start with the basics. How do we actually date this pregnancy? Well, we said that in singleton, at least in this country, in the UK, we tend to date the pregnancy in the first trimester between 11 and 14 weeks, or 13 weeks plus 6 days, using the crown rump lens. We don't really rely on the mother's last menstrual period. So for the twin pregnancies, we'll do the same, but the problem is that you have 2 babies. So you will date it again when the crown rump lens is between 45 and 84 millimeter. But it's you have 2 babies, so which one you choose? The larger. Yeah, that's what the guidelines say. You can debate it, but it's a larger. That's in spontaneously conceived twins. What about the one that had IVF? Well, they usually have their dates anyway, because they rely on the embryonic age from fertilization. Yeah? So that's IVF is easy, just follow their dates. In spontaneously conceived twins, use a larger crown rump lens. What about if the woman presents in the second trimester? So suppose actually the first time you see this woman was at 16 weeks, and she never had a scan before, or she doesn't really know. In this case, again, you will use the head circumference of the larger twin, the same principle. Okay? Or obviously, if she had IVF, it will be IVF, but often if they had IVF, they usually have a lot of scans. The other thing, which is probably the most important thing, is the chronicity and amnionicity, because that really determines the management of the rest of the pregnancy, and therefore is really crucial to get it right. So how do you determine the chronicity? Well, ideally in the first trimester, before 13 weeks, and there's a number of methods. Either you look at the membrane thickness, and if it's thick, it's dichorionic. If it's very thin, that means it's monochorionic. The T sign or the lambda sign, which is essentially looking at the site of the attachment of the membrane to the placenta. Because in dichorionic, there is actually chorion between the 2 membranes, so it's quite thick. So you have this appearance of lambda sign, while actually monochorionic, because the attachment is very thin, and therefore it looks like T sign. Obviously, the other thing is that number of placental masses. So if you have 2 placentas, it's very likely to be dichoric compared to 1 placenta. But be careful with the number of placentas because, in fact, in many dichoric twins, the 2 placentas are next to each other, so it looks like 1 placenta. And in about 3% of monochorionic twins, you will have 2 placental masses because maybe they're accessory lobe or something. Yeah, so don't just rely on the number of placentas. And in fact, the studies showed that the more signs you look at, the more accurate you are. So if I look at the different sex and the lambda sign and the thickness of the membrane and a number of placentas, you're more likely to get it right. For the ISUOG guideline, we said that we should really keep the ultrasound image, keep a record of it in the patient's record, because nowadays people move from one country to another, or she might have seen you today, but she will go to another doctor in a few weeks, and therefore it's really important that you demonstrate that you got the chronicity right. Obviously, it has some medical legal implications as well. What about if this woman comes in the 2nd trimester? So the membranes can still be a little bit thicker, but actually sometimes as the pregnancy advances, the membranes is no longer that thick and you can't really see the lambda sign properly. What should you do? Okay, you look at the baby's sex, because if they are different sex, boy and girl, well, it's likely to be dichorionic, yes, or if they have 2 placentas. So there are other features to look for. Okay, suppose actually it's difficult to determine a chronicity. But, so transabdominally, women are getting bigger. And also sometimes they have retroverted uterus, and therefore sometimes it may be tricky. In this case, you should do transvaginal scan. Because transvaginal scans, you go around, or you can get better quality pictures even in obese women or the woman with retroverted uterus. What about you've done transabdominally, done transvaginal, and it's still difficult. I can't really be certain. In this case, you get a second opinion, maybe someone more senior than you. Okay, suppose you got the second opinion, you called a friend, you did everything, and you're still not sure. What should you do? Refer to a tertiary referral center. Okay, the tertiary referral center, they saw the woman, she's 20 weeks, they have the same sex, looks 1 placenta, it's really tricky. In this case, you manage the pregnancy as monochorionic, because that means you'll have more scans, you'll be looking for the potential complication like CAPS or TTTS. Okay? Obviously, the other thing, so once you determine the chronicity, and if it's monochorionic, you need to decide on the amnionicity. And sometimes, in cases we see that, you say, oh, I can't really see the membranes. If you can't see the membranes clearly transabdominally, just be careful. Do transvaginal before you say it's a monochorionic monoamniotic twin. Or if you see the cord entanglement, fine. It's monochorionic monoamniotic twin. Okay? The other thing which is really important, and I don't think it's happening routinely, is the labeling of the twins. And it's really important. You might actually just know it yourself because you think this woman, you will see this woman during the entire pregnancy. But as I mentioned, people do move or get referred. And therefore, you need in your ultrasound scan report, you need to label the twin very clearly. So that means if I scan her today and in 2 weeks, Elizabeth scan her, she knows exactly which twin is which. Yeah. So for example, what we suggested is that you say twin A is a female, for example, on maternal right with a posterior placenta and marginal cord insertion, while twin B, between brackets, male, is on the maternal left with the anterior placenta and central cord insertion. And therefore, you put a lot of description, and therefore you consistent labeling, make sure that there's no confusion. Have you heard about the perinatal switch phenomena? You heard about that? Okay, so this is something that I don't think many people knew about it, and in fact, actually, even in my experience, I probably only knew the significance of it about maybe 5 years ago, when you come across a case and you learn from cases. So you need to know that when you scan a twin pregnancy, twin A or twin 1 on the ultrasound scan might not be born as the first twin. Yeah, so there might be a switch. So twin 2 on the ultrasound scan might be born as the first twin. And the significance of that is really mainly when you have a discordant anomaly that's not obvious by external examination. So for example, if the baby have congenital diaphragmatic hernia or hypoplastic left heart, one of the twins, and obviously you need to liaise with the neonatologist because this baby will need immediate peripartum intervention. Yes? So we had a case with a hypoplastic left heart, and woman, like what they do, twins, they come on Saturday at 3 o'clock in the morning in labor. So she have a cesarean section, and the neonatologist, okay, well, twin one is the one that have hypoplastic left heart. Twin one is the one that they started doing prostaglandins and intervention and so on. And actually turned up that twin one was a normal twin, and twin two is the one that had hypoplastic left heart. Okay, so how do you handle that? Maybe you just tell the neonatologist, look, there is a chance that actually the twin two is born first. Or you scan before you do the cesarean section, so you know which one is likely to be born first. Okay? This is what we put in the ISUOG guidelines, which I think is really popular, and many people, certainly in where I work at St. George's, we actually follow that. So this is the frequency of ultrasound visits and the monitoring what we do in twin pregnancies according to the type of twin pregnancy. And I'm just going to spend some time on it. So in a dichorionic or monochorionic twin pregnancies, you will see this woman in the first trimester between 11 and 14 weeks. You do the dating, the labeling, determine the chorionicity, and you offer screening for chromosomal abnormalities according to where you work and the parent's wishes. And then in dichorionic twin pregnancy, the next will be the anomaly scan at about 20 weeks. We obviously do the detailed anatomy, the biometry, look at the amniotic fluid, and cervical length, we will discuss it later, but also you have a whole talk about it tomorrow. And then after that, every 4 weeks. Every 4 weeks, because you're monitoring for growth restriction. For monochorionic twin pregnancy, the first trimester scan is the same, and then the next one will be 16 weeks, and then from 16 weeks, every 2 weeks until the end of the pregnancy. Why? Because we're monitoring for twin-to-twin transfusion syndrome, which often happen between 16, the commonest presentation between 16 and about 24 weeks, but certainly it can also occur later, often in the form of acute TTS. And in each scan, you will obviously measure the baby, so biometry. You need to measure the deepest vertical pocket. I know many people just look at it and say, oh, it looks okay. But actually, it's better, and the recommendation is actually you measure. Because measuring forcing you to look at it, and you document it as well. And then we also, in the guidelines, we said that we should be doing a Doppler, 20-week cervical length, and from 20 weeks, we should also look for the middle cerebral artery peak systolic velocity, because we're also screening for this condition called TAPS, or twin anemia polycythemia sequence, which not many people know about. Certainly in the UK, it's a little bit controversial because there's no sort of clear guidance about how to manage these pregnancies. And therefore, at least in the UK, where I work, this is a little bit, I don't think it's implemented in all the centers, but ISUOG, for best practice, we should be looking at middle cerebral artery, peak systolic velocity from 20 weeks, because you're screening for TAPS. Okay, is that clear? Easy? Okay. So what about triplets? Well, actually, Lisbeth will cover that in details, but certainly the guidelines did not cover anything about triplet. We focused on twin pregnancies. But just for this, so that many people, and including where I work, trichorionic, triamniotic triplet pregnancies will be managed almost as dichorionic diamniotic. First trimester, anomaly scan, 20 weeks, and then every 4 weeks. Okay, I'm a member of the NICE guideline update, and obviously it's not final yet because it has to be good to go to a stakeholder consultation, but there is very, very likely that they will be also every 2 weeks, just because of the higher risk of complication. But as I said, that's not the ISUOG guideline. The other type of triplet pregnancies, whether dichorionic triamniotic or monochorionic triamniotic, so they shared chorionicity. In this case, you treat them as MCDA because they still can develop all the monochorionicity related complications. They still can have TTS. And therefore will be the same as the monochorionic. First trimester, and then from 16 weeks, every 2 weeks. Often they deliver early, so you don't need to scan too many times. And if they don't deliver early, at least the NICE guidelines said we should deliver at 35 weeks latest. How do we screen for chromosome abnormalities? Well, we said we should, obviously, if you work in a country, you get biased by the practice in this country. So when we wrote the guideline, I said, okay, we'll do the combined test, because the combined test is what we do here. And the performance, the detection rate is about 85%, whether it's dichorionic or monochorionic, for about 5% false positive rate. okay? But in fact, actually, because it's an international guideline, and obviously there was experts from all over the world, they said, hold on, some countries don't have the biochemistry component of the combined test, and therefore they will combine maternal age with a nuchal translucency, okay? Suppose actually if you have a vanishing twin, in this case, it depends on whether you can see a fetal ball in this sac or not. If there's no fetal ball, in this case, you still can do the combined test. If you see a fetal ball, the biochemistry part component of the combined test is not reliable, and therefore you should just use the maternal age plus the nuchal translucency. And obviously we are in the era of the NIBT, or the cell-free DNA, and therefore that's something that you obviously need to know about it. And the detection rate seems to be almost, at least for trisomy 21, as good as in singleton. So in singleton, NIBT 99 for 0.1%. In twins, the initial data was 94 for 0% false positive rate, and I'm just going to show you some of that. So for example, the initial meta-analysis was 94% detection rate for about 0.2% false positive rate. The problem with cell-free DNA in twin pregnancies, and you need to be careful, is the numbers are small. Still, the numbers of babies with Down syndrome that's published is not great. And certainly, most of the studies use stored samples. Certainly, the performance is different, whether it's dichorionic or monochorionic twins. In fact, most people would treat monochorionic twins as singletons, because you have one genetics, one genes, is that? So they have the same genetics. And certainly, there's some companies would say they'll use a lower, sort of higher cutoff of fetal fraction in twins compared to singletons, so maybe 6% rather than 4%. This meta-analysis was updated in 2017, and certainly, as I said, the performance for trisomy 21 seems to be excellent, almost 100%. But be careful, there's only about 24 cases of trisomy 21 that's been reported in the literature compared to 1,000 of babies in singleton. What about trisomy 18 and 13? Much less, and the results are not great. So only about 8 cases of trisomy 18 and 13, and the detection rate is only about 60%, about 2/3. Yeah, so it's actually, be careful of trisomy 13 and 18 when using cell-free DNA in twin pregnancies. And certainly this is my personal experience. So this woman came from abroad to London because she couldn't have invasive procedure where she lives. She had actually Harmony test for the cell-free DNA, and she was high risk for trisomy 13. So she came and scanned her. She was about maybe, I think, 14 weeks at that time. So I said, look, actually I can't really see any markers of trisomy 13. Both babies look completely fine. So, okay, well, if you want to have amniocentesis, we'll do double amniocentesis, but we'll do that about 15 weeks. She said, well, I'm waiting in London anyway. Can I do something while I'm waiting because I'm really anxious? So after a long discussion, she decided to repeat the NIBT. It's the same test. What do you think the results were? Different. What do you mean by different? Be more precise. Come on. Normal, you're right. The results were normal. Same lab. Was it an IVF? No, spontaneous. Spontaneous. And she's not big, she's slim. Yeah, so I think just the message for me, at least from this case and from the literature, be careful of trisomy 18 and 13 if you're using cell-free DNA in twin pregnancies. So why is that? Because actually the fetal fraction, if you look at the fetal fraction, the median fetal fraction is higher in singleton twins. The total fetal fraction is about 1.6 times in twins compared to singletons. That's true. But actually, if you do the fetal fraction per twin, per fetus, it's actually less. Yeah? So they have lower fetal fraction. And also there's risk factors for failed NIBT, and the most important 2 risk factors is maternal BMI, because maybe it's a dilutional effect, and IVF pregnancies. And therefore, if you look at this graph on the right-hand side, for example, a woman who had an IVF, twin pregnancy, and BMI of 40, you see that the failure rate is about 60%. You can even sort of argue, should we really be offering cell-free DNA for this woman or not? So sometimes you have a failure rate when you send a sample, and the failure rate in singleton is about 3% compared to 9% in twins, higher failure rate. And when you send another sample, redraw another sample, in singleton you will get a result in about two-thirds of the cases, in twins only about half of the cases. So, and therefore we need more studies. So we did the Iona twin study. It's at 6 centers in the UK, and completed recruitment 1,000 twin pregnancies, and we just have only few that we're waiting for the outcomes for. Okay, so what about so you do the first trimester and you have a discordance in the crown rump length or the nuchal translucency. Is that important? And if it is, what is the significance of it? There's been lots of studies that reported association between maybe discordance in the nuchal and TTTS, or discordance in the CRL and selective fetal constriction, but actually the predictive accuracy is really poor. Yes? So if you see that, don't really spend half an hour talking to the woman about that she has very high risk of TTTS and selective fetal constriction. What you really should do is to spend this half an hour to look at the babies in detail and look for abnormalities. So look for detailed abnormalities because the risk is higher for abnormalities or aneuploidy. So even if you have 10% discordance of crown rump length, you see the risk of fetal abnormalities was 25% compared to 4% if it's less. So in this case, look for the detailed ultrasound scan and consider the option of karyotype. What about if there is increased risk? In this case, we prefer to do CVS and amniocentesis because of the risk of miscarriage. The risk sort of, if you want to have a diagnosis, so if the result is abnormal, it's much safer to do first trimester selective termination compared to later because the risk of miscarriage is lower. And therefore, it's preferred to do the test, the invasive test, that you can do it earlier, which is the CVS, compared to amniocentesis. Obviously, be careful because if sometimes, rarely, you might actually have discordant karyotype for monochorionic diamniotic twin pregnancies. And therefore, if you have a discordant anomaly in this pregnancy, you should really consider doing double amniocentesis because this rare condition when you have heterokaryotype, they have different karyotype despite the fact that they are monochorionic. As I mentioned, the selective termination in the first trimester is much better or much safer than the second trimester because they have lower risk of miscarriage and preterm labor. Monochorionic twin selective termination is obviously much more complicated because you have to do either cord occlusion or intrafetal laser or radiofrequency ablation. Okay, so twin pregnancies tend to have higher risk of abnormalities. And therefore, you really need to have dedicated time to have enough time to look at the two babies or the two fetuses. As I said, usually we do it about 20 weeks, but that can vary from one country to another, so between 18 and 22 weeks. And certainly, you need to look at the heart carefully because they have higher risk of heart abnormalities, particularly the complicated ones like TTTS, for example. If you have a discordant anomaly, so a twin pregnancy complicated by a discordant anomaly, what should you do? Well, it depends where you work. It depends on your experience. Not all of us have a lot of experiences. Some of us will do routine scanning. And therefore, if you have this case, because such complex, management is really complex, and various options have to take into account a lot of things. In this case, at least where I work in the UK, the guidance is to refer to a fetal medicine center. And it depends, for example, on the type of abnormality. So if you have a dichorionic twin with a lethal abnormality, so one baby have acrania, well, there is one option of doing nothing, just expect a management, yes? Or there's other option of doing selective feticide. In this case, for example, if it's monochorionic twin pregnancy with a lethal abnormality, well, you really should be careful because if this baby dies during the pregnancy, there is also the risk the other baby, that the normal baby is about 20 to 25% risk of death, demise, or brain damage. And therefore, perhaps you might want to consider the active management, selective reduction, to protect the healthy baby, the normal baby, from the demise, the consequences of demise of the baby that has lethal abnormality. Okay, so you can see sort of it's not straightforward. How do we do selective feticide in twin pregnancies? Well, in dichorionic twins, it's straightforward. It's ultrasound guided, usually transabdominal, intracardiac, or sometimes if it's technically difficult in the heart, you can do it inside the umbilical cord, so intrafunicular. Often people would use KCL, but also you can use lignocaine, depends where you work. And I said, ideally, preferably, you do it in the first trimester. Okay, suppose actually you diagnose a spina bifida, which is not often diagnosed in the first trimester, second trimester. And in this case, the parents want selective termination of the affected fetus. What should you do? Well, it depends where you work. It depends on the law, on the legal regulations. Again, we're lucky, we work in the UK, and the law is relatively liberal. And in this case, we have the option of delaying it to the third trimester, where you have lower risk of preterm delivery, or the consequences of delivery at 34 weeks or 33 weeks is much less than actually doing selective termination in the second trimester at 20 weeks, where there is a high risk of preterm delivery. Yeah, so if you work in a country where this is a legal option, maybe something you consider. What about in monochorionic twins? As I said, we cannot use the KCL because there is a shared circulation. The KCL will go from the one baby to the other one. Therefore, you have to use other methods, as I mentioned earlier, either cord occlusion, intrafetal laser, or radiofrequency ablation. And in the lecture on the selective reduction, we will go through that in detail. And with the counseling as well. Okay, so what about preterm birth? We have a whole lecture on it tomorrow, but I'm just going to touch and say what the ISUOG guideline recommended to do the cervical lens at 20 or 22 weeks, because this is the best marker for screening for preterm birth, and the cutoff is 25 millimeter. Okay, cervical lens less than 25 millimeter at 20-24 weeks have a positive likelihood ratio of almost 10 for preterm birth less than 28 weeks. It's not really good for preterm birth if you take a cutoff of 37 weeks, but more than 50% of the twins would deliver before 37 weeks. And in fact, some people would argue that using a cutoff of 28 or 34 weeks is probably more important, because this is a preterm birth that results in significant perinatal mortality and morbidity. Yeah, and cervical lens seems to be a good marker for identifying the pregnancies that will deliver quite early. So we work in the UK, so we have NICE guidelines, and the NICE guideline, the first version was published back in 2011, and it's undergoing an update now. And in the UK, we have this concept of the fact that if we will only screen if we can offer an intervention. There's no point in screening if there is no effective intervention. And when they reviewed the evidence at that point, none of the interventions were effective in reducing the risk of preterm birth in twin pregnancies. And therefore, despite the fact the evidence showed that actually cervical lens is a good marker, is a good predictor for preterm birth in twins, the recommendation was that do not use. Do not screen, because you can't do anything for it. Okay? But actually, I highlighted that in red because actually there is new evidence on the progesterone that was published not last year, the year before actually, which is a meta-analysis, IPD, so actually collecting or combining the data from these studies. And this is something called forest plot, but for people who don't like statistics, I'm just going to explain it to you. So if you have here almost 0.7, that means 30% reduction. So progesterone, from this data, progesterone seems to reduce the risk of preterm birth by about 30%. Preterm birth between less than 30 or less than 35. It doesn't seem to be effective if you use a cutoff of 37 weeks, for example. But not just reducing the preterm birth. This paper by Roberto Romero was actually looked at also the neonatal mortality and morbidity and found that progesterone does reduce the risk of neonatal mortality and morbidity in twins with short cervix in the mid-trimester, and there is no harm on the childhood development. And therefore, based on that, we should, or at least the ISUOG guidelines does recommend screening for preterm birth, and I think there's a high chance that the NICE guideline will follow. But obviously, I said we don't know yet because it's not being finalized. So what are the diagnostic? What about selective or fetal growth restriction? Of course, in the ISUOG guideline, we said we should monitor, we should screen for growth restriction, and then we came to the problem of how do you diagnose selective fetal growth restriction in a twin pregnancy. And if you look at the papers, it's different diagnostic features, different definitions. So, for example, we said in dichorionic twins, we just manage them as singleton. So if one baby have estimated fetal weight less than 10 centile, that's a selective fetal growth restriction in a dichorionic twin. In monochorionic twin, people said no, because a lot of them are small anyway. So we need to have an additional metric. So in monochorionic twin, selective fetal constriction is diagnosed when you have one baby with estimated fetal weight less than 10 centile plus inter-twin discordance of 25%. Around that time, there were other papers, like certainly from the Irish group, that suggested that also 20% discordance is associated with increased perinatal risk, and therefore we said, like, if you have 20% discordance, be careful. Maybe see this pregnancy more often. While if you have 25%, you have a diagnosis of selective fetal constriction. After we published the guidelines, we received a number of letters on various things, which is on one hand is good because people have read it, but on the other hand, you have to respond. So, for example, one comment was the fact that, well, actually, we don't do it like this in the States. We just use one baby less than 10 centile. We don't take into account the discordance. And certainly there were sort of different opinions. So we did something called Delphi. Delphi is a method to reach a consensus. So you get a group of experts and you get them to agree, try to agree on definition for selective fetal constriction in twin pregnancies. And what they actually agreed is the fact that if you have one baby with estimated fetal weight less than 3rd centile, that's enough to diagnose selective fetal constriction, whether it's dichorionic or monochorionic. But if you want to use a 10 centile cutoff, you need to have additional parameters, which is like the discordance of 25% or more, or abnormal umbilical artery Doppler, so PI above the 95th centile. I personally prefer this one because this one is really tricky practically, because most of the ultrasound database does not tell you the 3rd centile. Most of them are set up to tell you less than 10 centile. Yeah. The other thing as well is the exact centile is heavily influenced by the chart that you use. So, and therefore there is a variation of depending on which chart. While actually, and certainly we've been looking at our data, and we've got a new paper that actually say that if you use this definition, it's even if you apply it in different population, it's more consistent. So what's the best way of calculating the estimated fetal weight in a twin pregnancy? Should we just use equation that relies on the head circumference and abdomen circumference, or abdomen circumference and femur length? And in fact, the evidence suggests that the best, or the most accurate, if you use equation that has 2 or more fetal biometry. So the best, for example, if you use head and abdomen and femur equation that include these 3 biometry compared to maybe 1 or 2. And that's in fact consistent with the NICE guideline when they said that actually you should monitor for selective fetal constriction in twin pregnancy from 20 weeks. And in fact, the NICE guideline said that you should calculate the discordance in every scan from 20 weeks. And if it's 25% or more, that's an indication to refer to a tertiary level fetal medicine center. And the frequency of the scan should not exceed 28 days, so at least every 4 weeks. How do you calculate the discordance? Estimated fetal weight of the bigger baby minus the smaller baby divided by the estimated fetal weight of the bigger baby, and then you multiply by 100 to get the percentage. Okay, easy? Tomorrow we'll talk about how do you do it in triplet. Let's not complicate things. Oh yes, sorry. Yeah, you're right. Okay, so once you diagnose selective fetal constriction in a monochorionic twin, you must do the Doppler. You must do the umbilical artery Doppler, because you need to classify it into the Kratakos classification, type 1, type 2, type 3. Type 1 have this sort of positive endostolic flow in umbilical artery, tends the best, have very good prognosis. Type 2 have absent endostolic flow in the umbilical artery, is the worst one, because they have high risk of progression, high risk of demise of the smaller baby. And then type 3 is rare, is really rare, and you have this sort of characteristic pattern of intermittent reversed endostolic flow in the umbilical artery. And what's unique about this one is it tends to be unpredictable. So you scan this woman today, things are okay, and then she comes in a few days with demise of the smaller baby. But it's luckily it's not common. So again, when we wrote these guidelines, in TTTS is very clear. Yeah, there is randomized control trial, there is Cochrane review, you should do laser. In selective fetal constriction, there's nothing. They're just very like small observation studies, and a lot of it tend to be biased. There's no randomized control trials, and therefore it's really mainly based on expert opinion. So for dichorionic twins, people said, well, just manage them as singleton. In terms of the frequency of monitoring and in terms of the decisions when to deliver. For monochorionic twins, it's more complicated because if the smaller baby dies, remember we said it's about 20-25% risk of death or brain damage to the other baby, and therefore you have to sit down and discuss the option with the parents and say, well, there is one option is to do nothing and just monitor carefully, and probably will end up by having to deliver early, or actually doing active fetal intervention in the form of either laser or cord occlusion if you think the smaller baby have very poor outcome. How often should we follow up these pregnancies? Should I see them every day? Should I see them twice weekly or every week? So again, in dichorionic twins with selective fetal constriction, at least every 2 weeks, depending on the Doppler. In monochorionic twins, at least weekly, because they have higher risk of progression and as I said, the consequences of demise of the smaller baby. If you have a monochorionic twin with selective fetal constriction, and from the scan you think that there is a substantial risk of demise of the smaller baby, and what do you mean by that? How do you define the substantial risk? Is that, for example, if you have a very abnormal ductus venosus, reverse A wave in the smaller baby, you think actually that's a marker that has been shown in studies to be predictive of the risk of demise of the smaller baby. In this case, you should do something. And this something depends on the gestational age. So if this gestational age above 26 weeks, in this case, maybe depending where you work, you consider delivery after a course of steroids. If this pregnancy is less than 26 weeks, or actually delivery is likely to have very poor outcome for the smaller as well as the larger baby, in this case, you should consider active management in the form of either laser or cord occlusion. When should we deliver these pregnancies? Well, it depends. It depends on the type. As I mentioned, type 1 is very good. They tend to have very good outcomes, and therefore often we can carry on until 34, sometimes even to 36 weeks. While type 2 and type 3, where there is increased risk of progression and demise, often we get to 32 weeks and we deliver after a course of steroids. But if there are signs of deterioration, sometimes we do it earlier. If you have a twin pregnancy complicated by single intrauterine demise, it's really tricky. It's really tricky because often the parents are very upset, they're very anxious, they're worried about the other baby, the surviving twin, about this baby, what's the chance of this baby also dying. There's also pressure on you by maybe the staff. They say, well, are you going to deliver her? What are you going to do? And therefore, you need to sit down and discuss with the parents, and you need to counsel them about the potential risks. And the potential risks really are one of these four. What's the chance of demise of the co-twin? What's the chance of preterm delivery? What's the chance of brain abnormalities or neurological abnormalities? And these numbers vary according to the chronicity. So you can see monochorionic is obviously much higher risk than dichorionic twin pregnancies. However, both of them have very high risk of preterm delivery. More than 50-60% risk of preterm delivery if the one baby dies. So this is just a suggestion, a proposal of how to manage these pregnancies in a monochorionic twin, so single intrauterine demise in a monochorionic twin pregnancy. Obviously, you should, if you're not a fetal medicine expert, you should get this woman to be seen by a fetal medicine expert. If you are the fetal medicine expert, which is most likely, in this case, you do a detailed scan because you're trying to figure out two things: the cause of the death of the baby, the smaller baby, and also when did the death occur? Is it recent? Is it within the last 48 hours, or it's been actually going on for a week or two? Yeah, and then you do the Dopplers, particularly the middle cerebral artery peak systolic velocity, because you're looking for signs of anemia in the surviving twin, and if it is, you might want to consider doing blood transfusion. And again, in the talk on the stillbirth, we will discuss about how you decide to give transfusion or not. You counsel the parents, of course, and I showed you the figures from the meta-analysis. And then you should follow up this pregnancy every 2 weeks. And then because of the risk of brain damage of the surviving twin, In this case, you should consider doing MRI, not at the time of the diagnosis, because it's too soon. You know, if there's damage, it's too soon to see it. In this case, 4 to 6 weeks from the time of the diagnosis of the demise of the single intrauterine demise, because you're looking for major brain abnormalities. And it depends where you work. If you work in a country where late termination is a legal option, that's okay. I was presenting this once, and someone was from Pakistan, and she asked a very, very valid question, very valid point. And she said, well, why would I offer it? Like, we can't do termination. It's not going to change the management of the pregnancy. And she's absolutely right. If the parents will not, if this is not an option for them, perhaps there's no point in doing a fetal brain MRI. Just wait until the baby's born. Yeah? And then this is the last point, is a bit controversial, because certainly many people would deliver this pregnancy still early, at 34, 36 weeks after a course of steroids, because of the residual risk to the surviving twin. And often the parents actually quite like that. They're very happy with that. But it is controversial, because some people say, well, if everything's fine and the brain MRI is fine, why would you want to deliver this pregnancy early? Maybe just carry on for a bit more. TTDS, well, we're going to have a whole talk about it, but there is a standard diagnostic criteria. So polyhydramnios in one twin, oligohydramnios in the other twin. And quadrilateral staging is still sort of the most popular classification system, despite the fact it's not perfect. It's not necessarily, does not have very high prognostic value. And the cases don't just come from stage 1 to stage 2 to stage 3. So a lot of the times they actually just come with stage 3. But it still is the commonest classification or staging system used. As I mentioned, TTTS, there is plenty of good studies, including randomized controlled trials, that shows clearly that laser ablation is the treatment of choice for TTTS if you have a stage 2 or higher. What about stage 1? Well, there's no really. The randomized controlled trial that was published did not include stage 1 TTTS. And therefore, stage 1 is managed differently in different centers. Some people would just monitor for progression. Once it's stage 2 or higher, they will offer the laser. And some other centers tend to be more active management, so they will offer the laser as the first choice. But there are many things to take into account, isn't it? If this woman has severe polyhydramnios and she's symptomatic, or if she has short cervix, or if she traveled from another country to come and see you. So, there are lots of factors to take into account. What about amnioreduction? Is there any role for amnioreduction? Well, actually there is. Certainly after 26 weeks, which most of these cases will be acute TTTS, or let's say if you work in a country or in a place where you don't have this laser expertise and the nearest one is miles away, in this case, certainly there is still room for amnioreduction. And then people said, well, who should be doing laser? How many procedures should be for this center to have the competency? And people, as a consensus, said 15 procedures per year. That was not in the ISUOG guideline, that was in the ISUOG, the Royal College of Obstetrician and Gynecologists guideline in the UK. So what about stage 1 TTTS? What's the risk of progression? And it's only about 30%. So not all stage 1 TTTS will progress to stage 2 or higher. And when we published this meta-analysis about a couple of years ago, we actually looked at the survival rate according to the management of stage 1 TTTS. And you can see the numbers are not hugely different. And in fact, even, for example, for the laser, if there's a little bit less for double survival, it's often because they offer laser for cases that have progressed. Yeah, and therefore it's biased. But certainly the recent evidence suggests that stage 1 is not as benign as what you would traditionally were thinking, because they still have increased risk. So this is, again, observation studies. It's not randomized controlled trial, but certainly shows that doing active management, so whether amnioreduction or laser, have better survival compared to expectant management in stage 1 TTTS. And there was a RCT in stage 1 TTS that was led in by France, by Yville. I'm aware that it was stopped early, I think, because there was a difficulty in recruitment. I don't know the results. I don't think they have been presented or published yet. So let's go back again to what we're going to do every day. Should we screen for TTTS? Yes, of course. How do we screen it? From 16 weeks, every 2 weeks, we measure the deepest vertical pocket. What about the pregnancies, monochorionic twin pregnancies, where you have a discordance in the amniotic fluid, but it's not really severe enough It doesn't really qualify for polyhydramnios, oligohydramnios cutoffs. Obviously, these pregnancies have increased risk of developing TTTS, but in fact, these pregnancies tend to have very good outcome, more than 90% overall survival, and they have very low risk of progression to severe TTTS, only about 15%. Okay? But the studies that tried to look at any markers on the ultrasound scan, when you have the discordance, to try to figure out which one will actually have severe TTTS and which one will not, the predictive accuracy is poor. And therefore, we left by just monitoring this pregnancy on a weekly basis to try to figure out whether they actually will go on and develop TTS or not. So this pregnancy had TTS and treated by laser. How should you follow up? So should you see her weekly? Should you see her every 2 weeks? So the ISUOG guideline, we said you see them weekly for the first couple of weeks until clinical resolution of the TTTS. What does it mean? It means you don't have polyhydramnios anymore. And then after that, every 2 weeks, like back to normal. What about if you have single intrauterine demise after the laser? Because still there's risk of brain abnormalities, so you still consider brain imaging in 4 to 6 weeks after the diagnosis and neurodevelopment assessment at the age of 2. That's what we wrote in the ISUOG guidelines. I'm not sure that all the centers do that. Certainly in the UK, I don't think we are doing this routinely. When should you deliver this pregnancy? So TTTS treated by laser and the pregnancy is fine. No complication after that. Again, it's not based on RCT. It's based mainly on observation studies, and the suggestion was to deliver at 34 weeks after a course of steroids because of the residual risk. What about the risk of neurological abnormalities or brain abnormalities in following complicated monochorionic twins? So if you have TTTS or single intrauterine demise or selective vasoconstriction or TAPS, all of them, there is evidence in the literature, mainly observational, suggests that they have increased risk of neurological disability. And I said we were going to go through that in details tomorrow. But for everyday counseling, if you have a TTTS, for example, we tend to quote about maybe risk of 7% major neurological problems. And in fact, the initial study did at 34 months, and that was 7%, repeated on the same cohort at the age of 6, and it was about 9%. So actually, it does not necessarily change. It doesn't necessarily get worse with time. So if you quote less than 10%, you're probably right. Okay, we're left with only last 2 conditions. I'm just going to cover relatively quickly, which is the TAPS and the TRAP. How are we doing with time?
I think don't have any more time at the moment, but maybe these last few minutes.
Okay. Yeah, we have about until 10 o'clock. Good. Almost. Okay. So twin anemia polycythemia sequence. So this is a condition that was only described sort of in 2007. In fact, that was first described by a neonatologist, Enrico Lapriori from the Netherlands. And just this, like this picture, really, one baby is very pale because it's anemic, and one baby is very red because it's polycythemic. And it results from fetal transfusion. It's different to TTTS. TTTS is mainly amniotic fluid discordance, while actually TAPS is hemoglobin discordance. So one baby is anemic, one baby is polycythemic. And certainly when people looked at the placenta, including Lisbeth, who's placenta expert in twins, they actually found very small anastomosis between the 2 babies that resulted in hemoglobin discordance rather than amniotic fluid discordance, which is what you see in TTTS. There are diagnostic criteria for TAPS, and certainly started as postnatal. So it started, as I said, it's a neonatal, was described first by neonatologists. So with inter-twin hemoglobin difference of more than 8, plus at least one of the following. So reticulocyte count ratio above 1.7, or placenta with this very small anastomosis. That got translated into antenatal diagnostic criteria. And because using ultrasound scan, we can detect anemia using Doppler of the MCA peak systolic velocity. So if you have the anemic baby, which is a donor of peak systolic velocity above 1.5 mom, and the other baby, the recipient or the polysystemic of this peak systolic velocity is less than 1 mom. There's also a staging, and the staging, the antenatal staging obviously relies on the Doppler in the first instance. So the stage 1, if you have this cutoff, stage 2, if the cutoffs are worse, so the donor above 1.7, the recipient less than 0.8, stage 3 or higher when you have evidence of compromise of often the donor. For example, if you have cardiomegaly, if you have abnormal umbilical artery Doppler or abnormal ductus venosus. Stage 4 if you have hydrops, or stage 5 if you have deaths of one or both babies. And why TAPS is important? Because the outcome could actually potentially be bad. So it could be associated with neonatal death or neonatal morbidity. Okay, well, still the majority of babies with TAPS probably will have good outcomes and just hemoglobin discordance at birth, but certainly they could also have quite significant neonatal morbidity. Was it the donor or the anemic baby or the recipient baby? So TAPS is a little bit similar to selective fetal growth restriction. In fact, maybe even worse, because the evidence is very little. So small studies, small numbers, observational. And therefore, it's not clear-cut how do you manage these pregnancies. Do you just monitor them? Do you do active fetal intervention? And therefore, the options are either expectant, monitor, and deliver early, or actually giving transfusion to the anemic baby, but that's not even straightforward, because you remember, there's still anastomosis. So actually, sometimes doing transfusion to the anemic baby will actually make it worse for the polysystemic baby. Or actually doing laser, which I suspect is the probably commonest treatment at the moment, or selective feticide. For example, if you have one baby that's hydropic at 20 weeks because of TAPS, and you think the outcome is likely to be poor, in this case, certainly the option of selective feticide of the hydropic baby is an option. Should we screen for TAPS? Well, yes, the ISUOG guideline said we should screen for TAPS, and we should do that using the MCA peak systolic velocity in all monochorionic twins, and particularly the follow-up of TTTS that was treated by laser, because in fact the majority of TAPS cases, you will see them after laser for TTTS. Can we prevent it? Is there anything we can do to prevent? Well, yes. When you do the laser, if you do the Solomon technique, which means that you don't just do laser selective for the anastomosis, you do that and then you use the laser to draw a line, so almost diachronize the placenta, and therefore you probably will also stop the small anastomosis that you can't see during the laser. It shows to reduce the risk of TAPS. So that's one way of prevention. As I mentioned, is really the evidence is very little, and therefore each case you have to individualize the management. And I said most of these cases get seen in tertiary fetal medicine centers where they do fetal therapy, simply because they have more cases. They see more cases, and therefore you have more expertise in that. But certainly there's no good evidence. The last really condition that I'm going to talk about is a TRAP, or twin reversed arterial perfusion, and the management, well, actually, one second. Why is it important? Do you know what's TRAP? Okay, so you have and actually, again, Lisbeth will cover that in details, but you have one twin in a monochorionic twin pregnancy. It could be MCDA, it could be MCMA, and then you have a TRAP mass, or a cardiac twin. And obviously, the bump twin, this TRAP mass, or this acardiac twin, relies on the bump twin to keep going, and therefore there's an extra load on the bump twin, and the risk is that this bump twin can develop heart failure, and if you develop heart failure, you can become hydropic, and you can also develop polyhydramnios, and therefore the risk of preterm delivery is high. But also, really, in the old literature, you would see that sometimes people scan in the first trimester and they find that, and then when the woman comes back at 16 weeks, actually there's no blood flow in the TRAP mass anymore. Spontaneous cessation of the blood flow in the TRAP mass. And then some people say, well, why should we intervene? We just wait. Maybe it will stop by itself. Yes? But the problem that if you do that, there's about 50% loss rate. So if you see them in the first trimester and then you wait for 16 weeks, for example, hoping for spontaneous cessation of the blood flow. In about 50% of the cases, when they come back, the bump twin have already died. Yeah, and therefore there's a loss rate while you're waiting for spontaneous cessation. And that's really the concept of, or the rationale behind some people doing active intervention before 16 weeks. So if you see it in the first trimester and you diagnose a TRAP, you would just say, well, I'm going to offer fetal intervention, and usually in the form of intrafetal laser, which is essentially the same as the CVS technique, CVS needle, and then instead of the you remove the stylus and you put the laser fiber down the CVS needle, and you stop or photocoagulate the blood flow in the trap mass. And certainly, we publish and other people publish, by doing this, the survival rate is about 80%. But also people have reported doing other things later in pregnancy, so for example, cord coagulation or laser. Okay, last thing, monoclinic monoamnionitic twins, which we're gonna have a detailed talk about. So just in that ISUOG guidelines, we didn't really talk about it in details, but we did acknowledge the fact that the cord entanglement almost is a universal finding in all monoclinic monoamnionitic twin. And therefore, you really cannot rely the cord entanglement for the excess risk of death in the MCMA twin pregnancies. They do have higher risk of death, of course we do. But it's not just for the cord entanglement, because all of them have cord entanglement. Yeah, so there might be other things, and obviously Lisbeth will cover that. Another thing is that we usually, the recommendation is to deliver by cesarean section at 32 to 34 weeks. Okay, so I finished with covering the ISUOG guideline. As I said, this is the scope of the ISUOG document, and don't worry if you missed anything, because a lot of it will be covered in detail in the individual lectures.